Good morning. Good morning, everyone, and welcome to the Patient Org Day. Please welcome everyone. It's fantastic to see everyone in the same room now for one of the first times after COVID. Good morning, everyone, and welcome to this year's Patient Org Day. My name is Kjell Hansen, and I'm the chair of the European Lung Foundation, and also an asthma patient from Denmark. I'm delighted to say that we have patient organizations, we have individual patients coming from more than 30 different countries joining us today. So there are 100 delegates here in Milan, and there are nearly 40 patients joining us online. So I wanted to say a warm welcome to all of you, and welcome here to the Patient Org Day. So this is the first time that we are running the Patient Org Day as a hybrid event, and we are hoping to be able to run it very smoothly and with the same warm atmosphere as we do every year. And I hope that you are ready for that and will enjoy it during the day. I would first take a moment to welcome and also to thank the planning group who helped to put today's event together. So we have, of course, the chair of the Patient Advisory Committee, it's Mikaela Odemyr, coming from the Swedish Asthma and Allergy Association. We have Gergely Mesalos from the Hungarian Pulmonary Hypertension Association, Leon Galvin from the EU Pulmonary Fibrosis Federation. We have Jean-Michel Fourier from the Pulmonary Fibrosis Association of France, and finally also Stefano Pavanello from the Union of Lung Transplant Patients of Padua. So the planning group have put together a great program for us today, and there are plenty of opportunities for discussion and for sharing experiences, both during the planned sessions and also, of course, in the break. So we encourage to engage and ask questions and, of course, to network. There are a few bits of, and here they are, of course, and there are a few bits of housekeeping rules. So first of all, there will be a question and answer session after each group of speakers. Attendees in Milan, they can raise their hands, and someone will bring a microphone to you. Our online attendees, they can put questions into the Q&A box. And just for the record, there will be no stupid questions. There will only be good questions. And my co-chair, Hilde, and I will go through them and try to ask as many questions as possible. If you need support, there are ELF staff available in the room and online. There's also an online help desk that you can attend. And you can find the ELF email here if you need support, and there'll be people to help you. The event's website has details of today's program and speakers, and you might freely access those and find out more. The event is also being recorded, and they'll be made available on the ELF websites after the events, and you and others can also freely access this resource, and you can share it online as well. You might also want to get involved via the chat or on social media. If you do so, please use the ELF tag or the hashtag in order to include us in the conversation. We have built several breaks into the PAC program, but you're also, of course, free to step outside of the room when you need to. So I hope that you're all ready, because it's going to be a packed day of events. And with this, I am very happy to introduce my co-chair of this morning, and it's Hilde de Keyser. Hilde.
Thank you, Kjeld. My name is indeed Hilde de Keyser. I'm CEO of Cystic Fibrosis Europe, and I'm just like Kjeld, very happy to be here with you this morning and honored to be co-chair today's event. Welcome to all, also from my side, here and online. Let's go straight into it. I have the pleasure to introduce our first two speakers here. The first speaker is Professor Carlos Robalo Cordeiro. He is a lung specialist working in Coimbra, Portugal. His main fields of interest is interstitial lung diseases, and Professor Robalo Cordeiro is the current president of the European Respiratory Society. Our second speaker will be Professor Monica Gappa, respiratory pediatrician based in Düsseldorf, Germany. Her main areas of interest are early origins of lung disease, severe asthma and allergy in childhood. Professor Gappa is the president-elect of the European Respiratory Society and will take over from Professor Robalo Cordeiro as president during the ERS Congress here in Milan. Please, Carlos.
Hilde, thank you. Kjeld, thanks for the invitation to be here in this opening of the Patient Organization Networking Day. It's my pleasure. Thank you, all of you here in the stage and also in the audience and the online participation. I think this is very important. The first, as you mentioned, it's an hybrid, but it's also face-to-face, so it's very good to have everyone here in person. And it's my pleasure, it has been my pleasure to be president of the European Respiratory Society for some more 4 days, Monica. In 4 days I will hand over to you. And one of the main reasons for this pleasure and this very enjoyable, I would say, work, well, it's a lot of work, but it's a very enjoyable work. It's our close relation with the European Lung Foundation, our close relation with the patients. I think we are one of the few scientific societies with this model of organization so close in the executive committee of the European Respiratory Society. European Lung Foundation is represented, so patients are represented in the heart of our decisions. And this is quite important because we should never forget that we exist because of the patients. So we couldn't exist if there were no respiratory patients. Unfortunately, there are respiratory patients and they are very close to us. Yesterday we had a very nice event, public event with a press conference in the center of Milan related with our main aim and theme of this Congress, so pollution, climate change and sustainable developments. It was more related with clean air. With with an organization with Healthy Lungs for Life that we also share from ERS and ELF. And it was really important to advocate on clean air, as it is important to advocate on climate changes, as we are going to do here during the next 4 days, because we know that this is one of the most, for the WHO, is in the first place in the list of the global threats for diseases. And we know that it is the respiratory diseases and also the cardiac diseases that are the main problems affected by this air pollution and the consequent climate changes. So with this, I would like to wish you a very successful networking day. It will be very difficult to me, as you can imagine, to stay here for the day, but it was really my pleasure to welcome all of you to Milan, welcome all of you to the ERS Respiratory Congress. And if we are promoting this close relation with patients, if we are promoting clean air and combating air pollution and climate changes, we are also promoting physical activity. And Tuesday, we will have a lung run and also a lung walk. So if you didn't, please inscribe yourselves for this lung run. I did I was in the place this morning to see if it was efficient, and it was. I did the 5 kilometers lung run today, and I think it's important as part of our healthy lifestyles to do physical activity. For me, it's as important as to breathe. And I wish you a big success for this working day among the ones who are here and who will be remotely. And thank you again for the invitation.
Thank you very, very much, Carlos. Please, Monica.
Well, thank you very much for the invitation and a warm welcome from my side as well to all of you sitting here and all of you attending virtually. You have heard my name is Monika Gapper. I'm a pediatric pulmonologist, so I have a slightly different perspective on lung health compared to most physicians present in the ERS. So my mission for the year of presidency really is to increase awareness for the early origins of lung disease. You've heard about air pollution and the ERS and ELF activities for sustainable development, fighting against air pollution. But at the same time, I think we need to really raise awareness that if you want to fight lung disease, you have to start very early. You have to look after children and detect disease early, treat early, and if possible, prevent disease before it's ever going to happen. So this is really what I want to work on over the next year with ELF, with ERS, with all of you. I was very pleased to see that ELF has been able to recruit the first youth representative, a patient representative a few months ago. He is a 16-year-old from UK. I think his mother will be present during the event, but I understand she's not here today. And I hope we will be able to recruit more youth to represent pediatric respiratory issues in this setting. So, again, a warm welcome to you. I think it's very important that we work closely together as clinicians, as researchers, with you as patient and patient organizations that will help us to bring forward our ideas, our projects. So I'm very much looking forward to this event and wish you a lot of success and a very good day.
So I want to thank you both for joining us today and to come up and share your vision. Carlos, of course, your mandate is ending in 4 days. Thank you for all your support during the last year. And Monika, on behalf of the organization, I can only say that we look so much forward also to work with you on your vision for the future of lung health. Back to you, Hilde.
Thank you very much, Kjeld. This morning, we will be talking about PPI, patient and public involvement in research. And I was asked to briefly, and I tried to be brief, introduce the topic. Let's go back 45 years to 1978, far from here, Alma-Ata in Kazakhstan. That's where the WHO said, the people have the right and duty to participate individually and collectively in the planning and implementation of their healthcare. Luckily, PPI in health and in research has evolved considerably in those 45 years. What is PPI? PPI in research is research carried out with and by members of the public, patients, rather than to, about, or for them. An effective PPI must be realistic, bring added value, and it should be tailored to the nature of the research, such as size and scope, whether it's research-led or independently commissioned, and whether the research aims to design an intervention or evaluate it. I think PPI can and should occur in all stages of research projects, growing from setting out priorities together, over planning and managing research studies, to summarizing, distributing, sharing, and putting results into practice. PPI can not only promote a sense of empowerment and value among patients, it can also enhance patients' trust in researchers, improve researchers' insight into their own research area, and help researchers identify barriers and come up with solutions for them. Now, in 2023, in many countries, PPI is recognized as crucial for high-quality research with practical benefits for both patients and carers, but also researchers. Patients can provide both personal knowledge and lived experience, which complements perfectly with the perspectives of the academic research team. Although it evolved a lot, a recent review of 3,000 health research papers worldwide indicated the unevenness of PPI in research. 1/5 of the papers reviewed included PPI, but then it was about 44% in the UK and 3% in China, and European countries were all between that. I was asked to introduce, not to present about PPI, so I'm not going to go into the details why this is so important. I'm not going to tell you the examples we have in CF, and we're not going into the details about the fears there still are in PPI, which, according to me, we can all tackle. But I think I don't need to tell you, I think it shows I'm passionate about this topic, and I think this morning is a very interesting and important moment to talk about that. Thank you.
Thank you very much, Hilde. And now it's my pleasure to introduce the rest of the panel. So our keynote speakers is first and foremost Professor Michal Steinberg. She is a respiratory researcher and a clinician with a particular focus on bronchiectasis and adult cystic fibrosis. She's aligned with the Carmel Medical Center and the Technion in Israel Institute of Technology in Haifa in Israel. We'll afterwards hear from two patient organizational speakers. It will be Anke Wiedermann. She is the president of the esophageal atresia global support groups and a patient representative in the European Reference Network for Rare Lung Diseases. Luca Roberti is a patient with sleep apnea who founded the Patient Association Apnoea Italiani in Italy in 2016. Luca is active in various regional, national and European working groups, including the ELF Sleep Apnea Patient Advisory Group and the European Sleep Apnea Network called ENSAPO. There will be questions and answering following the presentations. But for now, I would like to hand the word over to Professor Michal Steinberg.
So thank you very much for the opportunity to speak today on this really important day. And I'm a clinician working in bronchiectasis and CF in Haifa, Israel. These are my conflicts of interest. And my aims today is to share the development of the patient involvement in bronchiectasis, to acknowledge the challenges and barriers to patient involvement and some solutions that we've come through, and to share some examples from patient-driven projects and future directions for our work. And I'll briefly state what bronchiectasis is and what Embark is in our history of patient involvement, some projects that we did for patients, inspired by patients, with patients, some challenges to involving the patients and some solutions that we come up with, and future plans, and then finally lesson learned on patient involvement. So on the first two topics, what is bronchiectasis? It's not very commonly known. So it is a disease of the airways. And if we look at a normal lung here, it has the tubes or airways, and bronchiectasis is mainly distorted tubes. And it's a chronic, lifelong, daily symptoms of cough and sputum with flares that we call exacerbations, periods of worsening. It was described over 200 years ago by Rudolf Théophile Lennec in France, who also invented the stethoscope, and this is a drawing of him examining a child. But it was pretty much neglected since then and until about 2012. It's not a rare disease. The prevalence is estimated at 1/4 to 0.5% of the adult population. So it translates to globally between 10 and 20 million patients compared to CF, which is about 80 to 100,000 patients worldwide. But it's not as common as asthma or COPD, which both represent between 5 and 10% of the adult population. EMBARK is a clinical research collaboration of the ERS, European Multicentre Bronchiectasis Audit and Research Collaboration. It was founded in 2013 by these three visionary people, Professor James Chalmers from Scotland, Professor Iver Polverino from Spain, and Professor Stefano Aliberti from Milan. And it was aimed to address an important need in bronchiectasis, which is no awareness, no treatment, underdiagnosis or misdiagnosis. So people with bronchiectasis were often diagnosed with asthma, COPD, whatever other lung disease that their physicians thought they knew. So the first action was to found EMBARK, which is a multi-center registry, which means gathering a whole lot of data, clinical data, physiologic data, data on bacteria from a whole lot of patients. And these, on the bottom, you see the original protocol publication and a recent publication of the results, actually, that was published in 2023. And it was more than a registry. It was a very ambitious aim to raise awareness, to create a scientific basis to attract physicians and the public to this unknown and neglected disease. Patient engagement in EMBARK started about 2015 together with ELF, they founded a bronchiectasis patient advisory board with expert patients from everywhere, contacts, a survey, physicians bringing in their own patient, and founded a patient advisory group for about 50 patients. And this group is supported regularly by the patient process coordinator at ELF, the wonderful Jeanette Boyd, and kept up to date with activities through regular newsletters. And the different patients have different levels of engagements, each according to his abilities and wants. One of the first projects that EMBARK and the patient advisory group did together was to set up research priorities in bronchiectasis, which is a consensus statement from the EMBARK along with patients. And it was comprised by revising, drafting questions and research questions, and then prioritizing them with experts, but also in a detailed questionnaire distributed to over 700 and more patients, also setting up a list of priorities. And this, for example, is the symptoms that patients complained about. And I'm not going to read that list, but they came up with a list of 22 research priorities according to both experts and patients together. And the beginning had some components. The first is the ERS bronchiectasis guidelines for care of bronchiectasis, which were published in 2017 and included patients. So 3 patients were embedded as full task force members, and comprising guidelines is a very detailed process with defining questions, finding the evidence, and constructing the recommendations. And this process really incorporated key input from patients, from the evidence to the decision, from looking at the data that we have from publications to forming the evidence. And patients' ideas and values were incorporated into each recommendation. And after the guidelines were published, a lay version was published for the patients. The European Bronchiectasis Registry also has patient involvement in setting up the case report form, or the data that we gather. The priorities were also set by patients, and there's still patients in the steering committee. There's a wide involvement in both physician education, because this is a not very well-known disease, and patient education. I'll go through that. And also involvement in clinical trials. So each clinical trial that is supported by EMBARK has patients on its steering committee that help to plan this study and research. The first World Bronchiectasis Conference was in 2016, and the PAG member, Marta Almagro, was giving the opening talk in that conference, telling her own story of her own disease, and really educating all the participants of that conference. Embark 2 in 2018 expanded and included several work packages, including the patient engagement activities in which I entered and took over. And this is from the ERS conference of 2018 with 3 of our PAG members and speaking about the patient engagement activity work package. And now we're at Embark 3 with many more activities, clinical trials, a biobank, collecting samples from volunteering patients, looking at genetics of bronchiectasis, looking at clinical trials and new therapies, and of course, a very, very important spot for the patient engagement, which expanded to now include physician education. So through the ages, or through the involvement, we came up with some challenges in patient involvement, and this is really nicely summed up in this Breathe paper from 2017 that you can see on the bottom. So the first is representativeness. So bronchiectasis is very heterogeneous. Some patients have this infection, and some patients have another kind of inflammation, and the severity and the ages and the reasons for bronchiectasis. So in each of our activities, do we want and how do we ensure that the patients that we recruit for engagements are really representative of the disease or disease state that we want? Is it important for us? Language is, of course, a barrier, and all the ELF Embark activities are translated. We need to find resources so that patients can travel to meetings. Patients feel that they know less. They have their personal experience, but they lack scientific knowledge. And we really have to be very aware of the perception of tokenism, which means, okay, we have a patient. What are they doing? We don't know. So we need to define roles for the patients, to make it very clear for the patient what we expect from them and what we want from them, and to give them guidance. Patients often lack confidence to get involved, and questions of conflicted interests, confidentiality, regulatory aspects involve patients as much as they do experts. Regarding meetings can be viewed as very formal, and the medical professions know each other, but the patients don't. Some patients who are attracted by some physicians in these meetings meet their treating physician, which can be awkward, and there's potential for very deep scientific discussions that go over the patient's head. Some topics discussed can be very disturbing. For example, if we say in a meeting, a patient with Pseudomonas will do badly, and the patient in there does have that infection. And also, we sometimes question treatments that may be taken by the patients in that meeting that can also be upsetting. So some projects that I want to go over. First is the patient representative and management boards such as Embark, Bridge, the Biobank, and the clinical trials, the patient bronchiectasis conference, some publications that we had that were a collaboration between patients and experts, and some resources for patients such as the bronchiectasis checklist, and then go over World Bronchiectasis Day and the event that we have, and new guideline development. So for the first, we have steering committee members at patients in each of the Embark projects, the Embark, the patient engagement, the Bridge study, which is the Biobank, the Grade 2 study, which is a clinical study now being conducted. Patient conferences have been conducted for 3 years now. They're held annually, virtually, with Zoom-based automated translations, which means there's captions in the language of choice. They're not perfect, but there are something. And the planning committee is patients with expert help. The speakers are both experts and patients. Some prefer to send videos in advance. And this is an example of the agenda of the last patient conference. Again, the planning was by patients, and we had 4 sessions, 2 for the newcomers, the patients who want to learn more about bronchiectasis and don't know enough, and 2 for the old and well-educated patients who want to know more about the research that's going on and the new advances. And one of the favorite talks that we had was pregnancy and fertility in young women with bronchiectasis, which was a patient-driven topic and a request of one of the patients. So we had almost 800 participants on the day from 78 countries. We answered in the chat 300 and more questions, and we had over 2,000 viewings of the video recording since then. So going on to the projects that were a joint project from a patient, and there were 3 publications now. The first is some advice on traveling with bronchiectasis, and that really was inspired by patients saying, we need to know what we do when we travel. So 13 people with bronchiectasis and 3 experts formed a list of questions. It was then distributed to the wider PAG, and then we formed an online questionnaire and sent it to experts and got back the answers. And these are the questions. Again, I'm not going to go over, but is it safe for me to travel? When should I travel? What should I pack? What documentation do I need? What kind of activities should I be engaged in? And we also included a huge table, this is just the first page, of all the medications that patient may take and how they're stored and what to do with sun tanning and alcohol, etc. And also revised a medical report for treatment abroad for patients to take to their treating physician, have it filled, and then be used when on holiday or traveling. The ELF webpage has a wide area of topics, and it's continually updated, patient priorities, a bronchiectasis patient checklist, which was formed based on the guidelines, which is a list of things that patients need to know and need to make sure that they're receiving based on the practice care guidelines published in 2017. Drugs in development, people really want to know what's in line, what's coming up, what drugs are going to be available soon, and that will soon update the 2023. And there's a self-care guide, which is different from the official guidelines. It's just, tips from one patient to another. And it was launched on World Bronchiectasis Day, which was July 1st. And it was written by a patient, Barbara Crossley, with some input from clinicians and a physiotherapist. And I like really this tip is, clear your lungs before you go to meetings. This is something that, one patient tells another, it's not the clinician telling them. World Bronchiectasis Day was July 1, and we had the event a day before. It was an event that patients registered, sent their questions, and then it was a panel of patients, experts, and answering these questions. And this is, of course, it was automatic translated, it was Zoom-based, recording are free to watch, and we had about over 600 viewings. So this is Barbara, the host, a patient, Donna, a patient panelist, a physiotherapist. Physiotherapy is very important in bronchiectasis. 2 clinicians, Dr. Askemet and Dr. Alterberg, and Dr. Amelia Schumark, who is a scientist working in bronchiectasis. And going back to the priorities, we really like to look back and see that the work is really progressed, and we do our research based on the priorities that were developed by patients and physicians alike. And I want to focus on number 22, the last ones, is a multidisciplinary education program is needed for bronchiectasis to increase awareness among non-specialists in secondary care and primary care, which means educate the carers. We're not there, there's still a lot of work to do, but there's lessons in bronchiectasis, there's crash course for GPs, we still have a lot of work. Recently, we had another very recent meeting with the PAG, and they suggested further projects such as a guide for sputum testing, very important bronchiectasis, more community services, more holistic care, a focus on gut health. And we discussed among ourselves and taken back the PAG with some of our recommendations. And in this month, we're going to discuss further and do some action points together, patients and clinicians and researchers. So to sum up, the Book of Psalms says, "From all my teachers I grew wise," and it's certainly right for me. I grew wise from my patients, my colleagues, my books, my everything. And what we know is that we frequently have a gap between how us clinicians, scientists think and work. We want evidence, we want data, we want science, we want guidelines. These things take time. The patients want the answers here and now, and they're right, and we need to work to bridge that gap. Incorporating the patient's input is very important to keep our work meaningful to patients, and patient involvement drives science forward in asking the right questions. Patients can be resourceful and have the answers, not only questions, but some challenges need to be acknowledged and addressed, such as language, such as proper guidance, such as making the patients comfortable and well-defining the patient roles. So my last slide is the thank yous for the Bronchiectasis PAG and many, many other volunteers. ELF staff, Jeanette Boyd, who's coordinating the PAG and keeping everything together in such a nice and polite and inviting way that's really remarkable. PIPA and KELD and all the ERS and ELF webinar support staff, and my dear, dear colleagues from Embark, who really prioritize everything that the patient working group or patient advisory group is putting forward. And I thank you very, very much for your attention today. Thank you.
Thank you so much. That was a very interesting talk. Can I invite Anke now for the next presentation, please?
Thank you very much. To be honest, I could stop here because you said everything what I wanted to say. My perspective is the patient representative perspective and how patient involvement driven by the patient organization can help researchers to set the right research priorities. So why I am here, I'm a bit the colibri amongst the colibris. Normally I'm on surgical congresses or on gastroenterological congresses because I'm a president of the esophageal atresia global support group, which is a congenital malformation of the esophagus. What's got that to do with the lung? Well, there is a connection between the trachea and the stomach, which you can imagine is not a good one. So today, still worldwide, most of the children are dying with this congenital malformation, and normally due to the lung condition. In the Western world, the first child could be treated by surgery in the 1940s, and they used to be healed by the pediatric surgeon. So sent home, everything is fine now. Unfortunately, the adult patient coming back now, and most of them have some lung issue, and many of them have a major lung issue. So, like your patients, they are often diagnosed with asthma or things like this. And it is an unknown field. We don't know the mechanism. I guess some of our patients would be patient for your group. And I show you what we did. I'm in the ERNICA network. It's the European Reference Network for the esophageal atresia. In 2018, we had a very nice consensus statement meeting, and we had 3 patient representatives involved. 15 pediatric surgeons, 1 gastroenterologist. Can you imagine they talked about the lung? They didn't. So what we said, we have to tell them it would be important. So we started to do, with the support of Audit, to develop a patient journey. It was a process with patient organization globally, and we sat together, we developed the patient journey from the prenatal diagnosis to retirement, because my dear colleague Graham Slater, he will turn 70 this year, and what is his biggest issue? I heard him yesterday coughing, the lung. So what we did, we didn't say we know better, we collected opinions, we collected data from patients. It was a sort of iterative process, no evidence, but valid. And then 2022, we had within our Ernica network a Delphi process about research priorities for esophageal atresia. Again, no lung issues by the surgeons, but this time we were prepared. And so our results were, now, out of 10 research priorities, we have 2 about the lung issue, which I think is quite good. And it's the major question, what are the mechanisms why our patients get so bad? I mean, we know why they have an initial problem, but so far it was said the tracheomalacia is hardening. My son is 24 years old. He was very blessed because his pulmonologist saved his lung. He's a CF doctor, and he said, I have no idea why it is like this, but I treat him like a CF patient in the first 3 years. And so now he's studying sport, and he's a quite good football player. So you don't do this with a bad lung. So the tracheobronchiomalacia in esophageal atresia patient is a second topic. Why does this type of tracheobronchiomalacia is developing differently from the normal newborn tracheomalacia? How to evaluate, how to treat. So those are our major topics. And then we have another interesting topic, outcome parameters, patient's perspective versus opinion of the clinician. That will be very interesting. But now I'm there, what you said, this will take time. So what are the answers now? And so I'm really very, very happy that I was accepted to speak here today, because it's a coincidence, or maybe not, that we are sitting here next to each other, because our patients need answers now. And every year we have amongst 4,000 newborns, 1 child with an esophageal atresia. And if there is not, by accident, a doctor who treats this child in a proper way for its lung, this newborn from 2023 will have a lung damage in 2043, which is not a good development. And maybe we know already at least some solutions how to protect this lung. It's a pity Monica is not here anymore, because that's exactly what she said. The first 3 years are the important one to protect those lungs. So, take-home messages. Patient journeys provide a really valid view on patient needs and knowledge gaps of the clinicians. And the rare disease patient organization provide added value for researchers and clinicians to identify the core outcome sets. If you don't look, you don't see. And I think what's an important topic, you said it as well, researchers and clinicians, at least in Europe, in the EU, can support the patient organization groups to apply money in research projects, because it's foreseen that if you have a big EGP rare disease project, you always have the possibility at least to apply the money for travel costs. It's not appropriate that those patients pay their travel costs on their own. So, thank you very much, and I'm happy that I'm here. Thank you.
Thank you, Anke. And indeed, it's beautiful to see how the 2 perspectives next to each other show how the knowledge and lived experience and the scientific knowledge together can bring us much farther than when we don't work together. Thank you. And then now I want to invite Luca on stage for his presentation.
Thank you. My speech, the title of my speech is a co-design of a secondary prevention and research project for sleep apnea with input from patient, health association and health professional. The name of the project is Sonno Amico, Sleep Friendly Project. Apnoici Italiani, the association we found in 2016, and represented the voice and the right of patients and caregivers with sleep apnea and related sleep disorder. ASILT is an association established in 1974 to provide supplementary health care for Telecom Italia Group company employees, which include 100,000 members and beneficiaries, family and retired workers. During 2019, we were running a national television campaign on the major national networks, a 30-second prevention spot for sleep apnea. ASIL president also is in the hall today, Dr. Trattabini, intrigued by commercial, contacted us. ASILT, being an health association and the mission to promote prevention campaign for its member every 4 or 5 years. In October 2019, we started the first encounter to plan the project. One of the consulting physicians and occupational medicine, part of the technical and scientific committee, Professor Romeo, proposed a campaign focused on sleep apnea. The main goal, the main purpose was to carry out a secondary prevention campaign of obstructive sleep apnea for members and beneficiaries. The second goal, make an important screening and diagnosis data on the target population are valuable to the scientific community and policymaker. The Sonno Amico project has obtained approval from Ethical Committee of National Research Center for an observational no-profit study. Target was population adult from 30 to 70 years in men and from 50 to 70 years in women. Bibliography show increased risk in female population after menopause. Screening target was proposed to 59,053 subjects. Members are resident in all 20 Italian regions. For 4x1, 4 questions which were 4 stop bang for sleep apnea, hypo-sleep can scale for excessive daytime sleepiness, some RESP for sleep apnea, and insomnia severity index. And other items on comorbidity and smoking were proposed to the members. The time 2 for the diagnosis. Our association has recommended and home care provider companies specialized in the management for home diagnostic tests. The subsequent examination report was entrusted to 6 specialized centers by remote mode, pulmonologists and neurologists. 5 of these selected centers were actively cooperating in our scientific committee. In time 3, after the patient received the result of the polygraphy by email, they were invited to contact selected center for therapeutic management supported by the ASILT health line. The timetable, say in 2019, we started the first meeting for the pre-design. In 2020, from January to December, the whole operation management part of the 2 times screening and diagnosis has been designed and set. Obviously, the COVID pandemic slowed down the operation time to the project. On 2021, the self-administered digital screening time by website, specific website, took place among July to December. On 2022, among January to December, full cardiorespiratory polygraphy type 3 were conducted at members' home. On 2023, we work on the data analysis. This is the flow chart you see on the center, the ASILT, on the left, the Apnoici Italiani, and the scientific committee from ASILT. Also the polygraphy report from the clinician for the physician, and also ASILT work with the survey coordination for the 2 phase, the 2 times screening and diagnosis. And the on-care provider work for provide the home sleep test at home to the members. This is for the time one, is some screenshot from the website. You see the frame screenshot is for possible comorbidity like atrial fibrillation. The second screenshot is from stroke, possible comorbidity. The third is for sleep apnea. The fourth was for insomnia. And the fifth is for problem about smoking. This is the first data about the stop bang, because we use the stop bang as a questionnaire, reference questionnaire to invite to the diagnostic test. The responders are 11,260%, the non-responder 47,837. At the online questionnaire is 25.4% of women and 74.6 men. In the second time, the polygraphy, the eligible for polygraphy are 8,646 people, performed 6,452, which we added another 308 people to low risk for the total of 6,860. The 18.1 are women, 81.9 are men. Age range in participant screening and subsequent diagnostic examination. You see on the left the legend, like stop bang questionnaire polygraphy. Clearly, from the age from 51 to 60 is about women and men. Also, the range from 61 to 70, the range from 51 to 50, 30 to 40 is only men. Result from screening to diagnosis. The responders to the questionnaire are 11,216 people. We use the stop bang questionnaire as a reference with a cutoff 1 to 2 yes is low risk, from 3 to 4 yes is medium risk, from 5 to 8 yes is high risk. We found the low risk 22.9%, moderate risk 47.1%, high risk 30%. The number of subjects eligible to polygraphy are 8,646. We perform medium risk 3,957 people, high risk 2,595 people, and we added also to assess the false negative 308 polygraphy. The total number of the polygraphy performer are 6,860. What we found, 34.5 person with mild OSA, 34.6 with moderate to severe OSA, 30.9 negative at OSA. Also, we found on the questionnaire the result about excessive daytime sleepiness. 86.26 are negative to ADS, 13.74 are positive to ADS. Also, on the comorbidity, we found moderate to severe, 13.4 with atrial fibrillation, drug-resistant hypertension, 23.4, type 2 diabetes, 14.1%, a previous stroke episode, 2.8. The key message. This study carried out by the Health Association show how relevant as their type of project to be developed by support of private entities to support the various health prevention development in the screening and diagnosis. Unfortunately, sleep apnea is a condition where patients are underdiagnosed and undertreated with huge social quality of life and economic setback. The involvement of patient association brought practical and operational experience with support of the medical scientific community. Telescreening and telediagnosis is an extremely effective and useful tool, even for a large number of people. This observational study can be considered the largest in terms of the numbers of participants ever done in Europe on a working age and a retired population. In the coming months, we will publish several papers in specialized scientific journals due to the wealth of information obtained. The research team will present a poster on 12 September in the Earth Congress. The title is a risk factor for ozone in a population of Italian telecommunication workers. I want to thank again the ASSILT Association, the President Tartabini, and all the team of ASSILT, Dr. Risotti and Dr. Francioso. Thank you for attention.
Thank you, Luca, for another great example and very interesting presentation. I also want to thank the three of you for keeping the times. That gives us a good time now for the Q&A. That is where we're going to move to right now. We will take questions from here in Milan and from the people that are joining us online. If you're joining us online, please put your questions, I think, in the Q&A. We will see them. Yes, in the Q&A we will see them, and Kjeld will raise them. If you're here in Milan, please just raise your hand. Somebody will come with a microphone, and we can, you can ask your questions. Can I ask you to be concise when asking your questions? That gives us the opportunity to answer as many questions as possible in the limited time we have.
Fantastic. And please mark with your hand if you have a question in the room. I would just start with an online question, and that's for you, Anke. So the question is, did you find any difference between the priorities of patients and those of clinicians in your work?
Do I have? Yeah. Yeah, sure. Without the patient journey, I guess we would still not have the lung issue amongst the 10 top priority for our network, because it is a surgical network. And 2017, I visited Milan the first time, and I said we need the connection between ear and lung and Ernica. And I guess now the time has come that we reach this. Yeah, it makes a huge difference. Yeah.
And there's also a follow-up for you. Did GPs respond positively to your recommendations and information?
So in our Ernica network, yes, because they start looking. That's what I said. If you don't look, you don't see. Now they looked and they were very... some were shocked and said, why didn't we see it? And we said, because you didn't look. Yeah. We see the adults. Yeah. And the pediatric surgeons are out of the game once the people are turning 18. And that's a little bit the issue. And then they are vanishing. We have very much difficulties to convince the GPs to provide the care to the young children they need. This is really a challenge.
Fantastic. Thank you so much. And
yes, I see a question here at table 2, please.
At table 2.
Thank you for the presentations. Very, very good. The question I'd like to ask is, how do you disseminate research results to your patients? It's often a difficult thing to do, to translate the research results so it's understandable for the patients, and it's often neglected at the end of the study. So are there any strategies that are used to do that?
Yeah, so that's a great question and very important. So there's several ways to do it. And one way is to disseminate for major papers and a lay version, a shortened lay version that is understandable for everyone. The second is that our PAG, our wider group, has frequent meetings with us, and some of the meetings we give a highlight of what's in ERS conference, what's in the World Bronchiectasis conference, the news. There's also bronchiectasis research news, several web pages, and the ELF web page, of course, which also summarizes major findings. So great question, and of course it's very important. So patients need and want that information.
Great. And I see at table 8 as well. Yeah.
Hi, I'm Lucy Dixon. I represent PCD Support UK. And it's just a question for Michelle. It was a really interesting presentation, and PCD is a kind of subtype of bronchiectasis. And I was just interested in whether you have strategies for increasing the representation of diverse populations, and I'm going to define diversity quite specifically here. So in PCD, we have a South Asian community that are predominantly affected, or more, yeah. And I was wondering, have you got good strategies for trying to get more people from different backgrounds on your studies?
This is really the question of representativeness. So if we're doing a study on PCD, we will want people with PCD. So far, we didn't address that, unfortunately, but I think if we start to look more at phenotypes, we will. One of our priorities that I didn't think about was doing a pediatric extension of EMBARK, because PCD often is a genetic disease, starts at childhood. We don't have a good representation of pediatric patients, and I think we are losing some patients in the transition from pediatric care to adult care. And I think this is one of the priorities that we need, and PCD is a great example for that. So this is really an action point. We haven't looked into that yet, but you're right. Thank you.
Great. And I see at table 4 first.
Good morning. My question is about bronchiectasis. And first of all, congratulations for all you did for this disease, because I have lived most of my life as a bronchiectasis patient, and I know what it means to be forgotten by everyone. So I am always a little bit polemic in my life when I see something that are going wrong. And I felt very angry as a bronchiectasis patient, because I had only doctors could find only one mutation in my genes, and that's why I was considered bronchiectasis. And as I said, I felt angry because I knew that my disease was very similar to cystic fibrosis, but no cystic fibrosis center wanted to help me with this disease. And then now, like a magic, they found the second mutation, and now I'm a cystic fibrosis patient, and everything was open to me. So did you find the same feeling as I found in Italy, to be left apart from the cystic fibrosis work only because of one mutation? Okay.
Well, we see cystic fibrosis as a very a subset that can be included within bronchiectasis, but has other features. Historically, cystic fibrosis are treated in different centers, different drugs approved for CF and bronchiectasis, but I think in the future we'll see more of the common pathway of treatments, because the lung disease is similar in CF and bronchiectasis. So some of the treatments we used to borrow from CF, now we're in a different position. We're developing treatments for bronchiectasis, which can also treat CF. So sometimes it was the orphan child of CF, but much more common than CF. But I think we're in the right place now, being a disease in itself. So thank you for your comment and question.
Thank you. And I think we have a question at table number 2.
Thank you for the presentations. This is a really interesting topic and something which I think is extremely important for research. I just had a question around training patients when it comes to being involved, and I'm not sure, it may have been mentioned and I missed it, but you spoke specifically about the challenges that patients have about information they're going to learn and they're going to hear about during discussions on the research that's taking place. How do you prepare patient groups for that? Because that's one aspect. And the other aspect is, I actually am a CEO for a patient organisation, and I think engagement with patient organisations in the very first instance is critical, because we have links to those that we feel will be able to help with the research and give a lot of really good feedback. So that's something I would definitely encourage. And secondly, yeah, just some information on how you approach that training.
Yeah, so it was especially important for the guidelines development, because guidelines is a very structured process, and you have to understand how guidelines are formed, how we first look at form the questions, look at the evidence, find the recommendations, and then we give the guidance to patients. So before engaging patients in the guidelines, they got a booklet of how guidelines are formed and what we expect patients. So I'm going to be a little bit long and give an example for what. So one important question that we have is how strongly to recommend an intervention that has some benefit but some side effects, like inhaled antibiotics in bronchiectasis. They work, they reduce exacerbations in about 20%, which is good. They take time, they're quite costly sometimes, and they can have side effects such as coughing and difficulty to breathe. So where's the balance? I think these type of questions where the evidence is not, it's a super effective drug, everyone will want that, then probably, patients and research will feel like. But it's the gray zones, the interventions that we're not really sure about and what their place are, that we really need the patient view. And these things are in the guidelines. And in the committees, it's really useful for the chair and for someone who's running the committee or the meeting to approach the patient and to say, listen, we have this drug. It's doing, improving, 60%. It has these side effects in 20%. Would you want this drug? Would you not want this drug? What are your values? So really asking the right questions, asking in a way that is meaningful for the patient, and also providing guidance is very important. So the guidance regarding the guidelines is there. We just talked about developing new guides and new resources for patients. So yes, there has to be written information. There are places that I saw that really have an online workshop for patients, which is also a good idea. And yes, we have to prepare for that.
There is another question.
I just wanted to add two things. I think one important thing is this informed consent on treatment recommendations which are not gold standard or evidence-based. I think that's our role as patient organization. This is nothing a single patient can develop. So this is our expertise to develop and to know that every patient is different. So the one patient will decide, I take the risk, and the other one will say, oh, I rather leave it. Especially if you are treating, if you are with parents in the dialogue, because they decide for a very long time. That's the one issue. And I think I mentioned it in my presentation. For dissemination of those guidelines in a lay version, again, the patient organization via their members are the perfect dissemination, because they take the lay version to their GP, which then hopefully the GP understands as well, and then they can go on eye level to develop a good treatment for the child or the patient. That's I wanted to add.
Very, very important, Anke, and I really think patient organizations have an important role to play here. I do agree. I think I saw a question there at the back.
Thank you. I'm Lilia Bilenka-Janté from France, French Federation of Association of Patients with Respiratory Diseases. My question, how to motivate the patient to take part in the studies? And particularly the old patients. You see, our federation receive the proposition, the questionnaires, rather many. And our patients, very often, they must work for the study, it's a work, and they won't see the results because they are older. So I confirm that in real life, they sometimes are not motivated to take part in the studies. Thank you.
Anyone? Are you happy to take that? Yes. Yes, please.
So are you referring in participation in clinical trial as participant in a clinical trial, or in the advisory committee or planning committee? So which is what you refer? The clinical trial. Yes. The clinical trial. So you know, it's often we just explain the best we can to the patient and say some clinical trials, there's no personal benefit for the patient, and we openly say it, we have to openly say it. For example, in a registry will not give you medication, it will just collect the data. And some people are happy to contribute to others, knowing that they themselves will not see benefit, but the benefit will maybe for future generations. A lot of people are happy to do that. But, you know, it's up to them, of course.
Fantastic, thank you. And I just wanted to bring Luca in also, because you had the co-design project. How did you motivate people to be a part of your project?
Okay, the people are members of the ASILT Health Association. ASILT developed a few communication projects inside his association to promote the involvement. But you see, the target was 59,000 people. But not only 11,000 people is involved, because normally when you organize this kind of study, the people think have this problem, make the test. Not all people, because if you don't have some symptoms, maybe you don't perform this kind of test. But it's a very large study. We are happy because we involve also. We started the project during the COVID period. This is not simple delay the start of the project, but I think it's a large number. But we work. ASILT work a lot with the communication, like with the email, with the registration of the database, and
fantastic. So I don't recall about the age difference in the study. Were there many older and younger people, or mainly in the middle?
Yeah, the target is in the man 30 to 70 and the woman 50 to 70, because we know in the sleep apnea the woman after menopause increase the numbers. But we discover a very big number, because 34.5% with the apnea moderate to severe need the treatment. This is important for prevention for the health work found, because you make prevention also to the work people, because our people work, maybe our driver, you know about the sleep apnea, you have serious problem about excessive daytime sleepiness. The target, but the medium age is around 50. But in Italy we have a big problem, because for example, in Italy we have around 300,000 patients in therapy. In France we have 1.5 million. In Italy we are in delay. This kind of project is very important to make prevention, because it's very important, the prevention. we hope other project about this kind of prevention, secondary prevention, because also the President informed me that the Federation of Health Fund Association released a new article in this statute to promote this kind of project for prevention, because normally the prevention is in charge of the national system, but we know the national system don't invest many money about prevention. It's important the private health fund invest in prevention, for example, for lung disease.
Fantastic. And Anke, you want to come in?
Just as additional information, what we learned that if the doctors and the patient organization together write to the patient and say it's valid, it's important, and our community will benefit, this helps, at least with parents. I mean, I can understand that maybe with elderly people it's more difficult, but with parents it works very well.
Fantastic. So I wanted to turn back to the online questions. And there's a lot of bronchiectasis people engaging with us today. So that's very well. It keeps you busy also, Michal. There's a question from Lisa saying, as a bronchiectasis patient with aspergillosis bronchiectic, is there any research plans on the prevalence of aspergillosis in bronchiectasis patients and tackling prevention earlier? Also, is there educating medical professionals to look at aspergillosis when a patient's symptoms are not adequately controlled?
So there's wonderful research going on in that fungi or in general. Aspergillosis is a part of a fungus infecting the lung. So there's important research going on with a group in Singapore and a group in EMBARK. And actually, we use the samples from the BRIDGE study, which is the intervention of the biobank part of EMBARK, to take samples from respiratory, from secretions, from sputum that people send in, and then look for these pathogens, the fungi. And there's some very important outcomes in fungi. It's not all that clear what the role of and whether we should treat with specific medications. But research is still going on, and once we have answers, we will have the place to place recommendations. So we're not quite there, but we're on the way.
Thank you. Thank you. A lot of interesting questions and a lot of, I'm sure, questions that still remain. One of the things I heard here, and I'm very convinced of, is that the collaboration between patients, patient organizations, and researchers is very strong. This was the last question for today, so I hand over to Kjeld again to
yes,
finalize.
so I will finalize the session. So first I want to say thank you very much for engaging with us on this session, and of course particularly thank you to all our speakers. First and foremost, we had Carlos and Monica who had to leave, of course, and we look forward to engage with them in the future. Then Michal, Anke, and Luca, thank you so much for excellent presentations and for engaging on the questions. So I wanted to welcome back everyone. So it's been so excellent to watch you engage face to face with each other, and for us also to have a small break.
Indeed.
Yes. So now we have a chance to hear all the experiences that we had gathered through the discussions, share them, have a small discussions, and then look towards the feedback that we get out of it and what we can take with us moving ahead. So I wanted to invite you, Hilde, to share the first light bulb moment.
I will try to read out what you in each of your groups have given us as light bulb moments indeed. The first one I have here is enough sufficient resources on patient side, both people and money.
And which table was that?
That was table number 4.
Yeah. So, and I do have from table number 8, so to involve more patients from the rarely heard communities, modify the packaging, do something fun in a neutral setting that I assume it also means getting more out of the office and meeting people, and don't make research the main topic. I think that's a very good advice to have more down-to-earth conversations and facilitate people to be able to attend and gain trust. So I just wanted to call out to table number 8. Do you have any experiences that you want to share or with the group, or is it mainly an overall discussion? Table number 8, yeah.
Hi. So I think we had some really good discussions on our table about different approaches that all of my colleagues have taken to involving people. And one example, I think my colleagues have asked me to speak about an example that I shared. We run a very tiny patient organisation in the UK. Research is really important, but trying to get people involved is very challenging. And so we are trying to do more fun things. So we hired a room in a theme park and we bought 150 tickets and said, it's free, bring your families and you can come. And we had a room and people would just come in all day and talk to us, or they could just go, they could ignore us and go and play on the rides. And I was saying it would have been a really good opportunity to have researchers there, just informally, casually, because we had so many conversations that were relevant to research, and it was a very different audience to who would come to our online talks that we run, where they are researchers talking about their work to a lay population. So I think we will try and do more things like this in the future.
Amazing.
Very interesting. At table 5, they came up with patients can help doctors to attend specific congresses to update their knowledge about research projects and make contacts with researchers to get their patients involved in the projects. So that goes back to how involve patients more in projects.
Mm-hmm. And we do also have from table number 2, so talking more or focusing more on communication and education, and of course also having the respect between one another. So I think the respect is also a highly important topic to keep in mind, and the openness perhaps also.
I think so. When I look at these, respect and trust are two words that come back very often. Table number 7 has 2 light bulb moments. You are heard and you are seen with an exclamation mark. I think that is very important indeed.
Great, and we have from table number 1, a mentor or a person from the beginning of trial to guide and help you through the process, and also to help with the information and dealing with matters. So in order to avoid that people drop out. So is anyone from table number 1? Do you want to give an example or elaborate?
We have quite a lot of experiences with research here in this group, fortunately, and we are representing different European countries from the north and from the south, so it was quite interesting. People participating not only in trials, but also in health technology assessments and clinical guidelines. What we noticed is there's always a lack of organization and a lack of personalized attention. This is why we think it's absolutely necessary to have a specific tutor, a specific person who can resolve any problem at the first moment, you know, from the beginning to the end. I don't know if you want to say anything.
Well said, then. Yeah, thank you so much.
Table number 9 There we get education and information are fundamental to bridge the gap between research and patients, for patients to feel empowered and informed to shape research. And then it says regulation is different in different countries. For example, Latin America can prevent early investment in clinical trial development. I'm not sure I get that right. Table number 9, is there somebody who can expand a little on that?
Yeah, thanks. We've got a really diverse group on our table, so different experiences in different countries. And actually, although there might be a desire to involve patients early in clinical trial development, local regulation or regional regulation prevents that. So just being mindful of the different challenges that we face.
Thank you.
So from the online session, each individual patient is crucial, and the task is to make them really understand their importance. I think that really also comes home with me. I think probably many patients don't realize how important they are and how important their lived experiences are also for clinicians to advance their work.
Certainly. Another online light bulb is promote education and adapt to different audiences, so written, digital, and lay language. And that's something that was discussed also this morning, right? The lay language and how important it is that people are informed and can understand what it is about. So again, a very important insight, I think.
And from table number 3, then patient organizations are not recognized in expertise and knowledge and time investment in networking efforts, and also in terms of compensation for the time that they put into it, time and effort and experience they put into their work. So the respect, again, is an issue on this one. And perhaps table number 3, would you care to elaborate on this? So respect also appears to be a returning issue.
Sicuramente una grande difficoltà che si trova, che rileviamo in Italia, molte delle quali già dette da chi ci ha parlato prima di me, è sicuramente una difficoltà per il paziente di arrivare ad avere l'informazione che sul territorio nazionale c'è uno studio, una ricerca che riguarda la patologia di cui è affetto e a cui potrebbe partecipare perché ha le condizioni per parteciparvi. Questa è sicuramente una grande difficoltà. E poi ci sono delle difficoltà oggettive che sono quelle che l'Italia è lunga, è stretta ma lunga, e quindi spesso gli studi, le ricerche, insomma, è in un paese lontano da quello di residenza, e per esempio un paziente di Taranto per andare a partecipare allo studio clinico a Milano deve fare un grande spostamento molto impegnativo sia in termini di tempo ma anche in termini economici.
Yes, regarding information, first of all, access to information. There is no uniform access to information to research for patients. And also regarding the respect for patient and for patient organizations in terms of their expertise and knowledge. They're not considered enough in terms of the time they invest for research, for participating in clinical trials or research, and also in terms, in economic terms. They are not recognized as with reimbursements for their time, their risks, and their effort, and this is what we find as a main difficulty and barrier in our countries.
Thank you so much. That's beautiful.
Yes. And then I have the light bulb of table number 10. To reach seldom heard populations, indeed very important, and trust with a big exclamation mark. Use organization people trust. Use leaders in communities that people trust, and do work that gives outcomes people trust. So the trust is here indeed a very important issue.
So, and which table was that?
10.
Table number 10. So maybe someone from table number 10 would like to elaborate?
Hi, I'm from PCD Support UK. My name is Abdullah. In terms of trust, it's more about diversifying what we have in research. We know in a lot of the South Asian, a lot of the cultures, they're very close in their community ties. And we have a lot of information about, they're very close to their local leaders, for example, mosques, gurdwaras, chapels, etc., what you might have. So maybe it's about reaching out to those leaders who they trust already and getting them more involved to be able to promote more research. And I think a lot of it is more about experimenting different ideas that we can, and targeting and splitting the target between the younger generation and the older generation in research.
Thank you so much.
So if I look at it, Kjeld, what I hear is a lot of people talk about education that is needed. A lot of people talk about resources that are needed to do effective PPI. And then there is the issue of respect and trust between partners, being involved as equal partners, trusted and respected.
Definitely. So, and for that, I think, of course, that's something that we will keep. We'll keep the notes, of course, and keep working on this. I think in order to bring the next generation of patient advocates forward, maintain the existing contingent, that's definitely something that we will need to debate more publicly, also on how we can raise the respect for the individual patients and make sure that their experiences, the lived experiences, are seen as equal and complementary to other kinds of experiences. Indeed, a very fruitful and great opening session for us to be part of and to discuss with excellent panelists and excellent groups in the room. So I would like to thank the group facilitators first and foremost for their support, and it will bring this plenary session to its end. We will take a break, have some lunch, there will be lunch, and then we'll return 2:05 for the afternoon session focused on mental health and lung disease. In that session, you will have 2 new chairs. So I also want to thank you, Hilde, for stepping up to the podium and discussing.
And you, it was a very interesting morning. I think we have all a lot of things to think about, take home and work on in the near future. So thank you too, Kjeld, and enjoy your lunch, and see you in the next very interesting session.
Look forward to the mingling. Yeah, and the next session is then co-chairs by Liam and Michaela. So they will welcome you back after the break. And that is at 2:05 from myself and from Hilde. Thank you so much. And looking forward to the networking and, of course, the lunch.